Yeah. So this is about a 52-year-old male, an auto driver, had a fracture acetabulum and the femoral head of the right hip, and initially he was managed conservatively. So this is 8 weeks post injury. This is the Jude view. And then at the end of 3 months post injury, so he underwent a total hip replacement for the same, the form of uncemented stem and a cage with adequate amount of medial bone graft. Then at the end of 3 months post surgery, he ended up with dislocation of the hip. And initially he neglected the treatment for dislocations. He was trying to walk with walker, completely out of job, not much mobile. He was almost bedridden and he was not able to walk, pain and so on. Due to financial economical conditions, he was not able to carry out further line of management. So he dragged on for almost 1.5 years post index, the primary surgery, was trying to walk with the dislocated hip. This is almost 1.5 years, 18 months post the primary surgery and after dislocation also. So now at the end of 1.5 years, pain increased, immobile, limp. So he wanted to get it rectified. So he went to the primary surgical team. So for some reason, this was the done immediate post-op. So they have found exposure was difficult because it was the trochanter and the hip was dislocated for almost more than 1.5 years. The stem was removed by an ETO, I think, probably. They had difficulties in exposure, so that difficulty in cage removal. And of course, not much details were known about the procedure at this stage. But the unfortunate thing is that patient had infection after the removal of the stem. So there was a pouring pus, acute infection, and it was found to as MRSA positive. So later again, within a month, the same team went ahead with all difficulties. They have removed the cage also, and adequate antibiotics were given as per the protocol. So patient was again asked to mobilize as an excision hip arthroplasty. So patient started walking on the hip with help of a support, but he ended up with fracture of the proximal femur along with the greater trochanter. So this is almost 1 year after debridement. Patient were trying to mobilize to be mobile, but his pain increased. He's out of job. Is because his profession was auto driving. Movement was restricted, but he wanted a stable and a mobile hip. So he was not happy. So it's almost now he was out of job for almost 2.5 years, almost 1 year post debridement after the removal of the complete implant. So this is what he presented to me or to us, to our team, where the wound was completely healed. The blood parameters were almost normal. He had a shortening of almost 5 inches. So what to do next at this point of time?
Sir, I would like to get a traction view, sir. If it is coming down or not, clinically, I want to check it off, sir.
Yeah, we have a traction view, but I'll show it.
Yes, sir.
But it never helped. There's no traction, not
Yes,
even
sir.
1 inches of movement of traction.
Yes,
But we have done it. I'll show you how to.
sir, I will proceed with taking a CT, sir. I'll look for any walls are there or not, and I'll plan the patient with the highly porous tantalum and augment, sir. It might require more than 2 augments, sir. And stem side, an SL Wagner trying, sir.
So this was what you asked, is the traction view.
Okay.
A skeletal traction on the upper tibial pin traction was done.
Okay, sir.
And this was the traction view, and this is a CT scan, what you have asked.
Sir, I'll plan for an STO also, sir. But cup, I'll try to put a highly porous cup with an augment, sir. I'll try to put an augment. superiorly and posteriorly, sir.
Augment superiorly and posteriorly.
Yes, sir.
But you can see adequate amount of bone graft, medial wall with anterior
Yes, sir. Step by step,
column.
only, sir. I'll just to try to ream and put an highly porous cup, sir, and I'll try to put the iliac screw, sir. With the ilium and pubic screws, I'll try to ischial screw. I'll try to put, and then if required, I'll put an augment, sir, to support the cup superiorly,
Okay.
mostly, sir. And in stem side, I'll try for an STO with an SL Wagner, sir. If it is very
Subtrochanteric osteotomy in this conical femur.
yes, sir. Subtrochanteric osteotomy, yes, sir.
You have a, Bharat, is there a 3D? Is there a 3D image?
I had, sir, but not here in this presentation, sir. I do have,
Yeah,
sir.
these kind of things, somehow working backwards is always helpful, because otherwise there's so many sagittal and all this reformatting you have to do in your head. And
Yeah,
still,
this I thought it was sensible for from the cup aspect, sir. That's what I used this particular slice. Yes.
yeah, because I mean they've reconstructed and there was a cup there. So I'm just thinking how much of the original anatomy of the cup has been restored, because that would make things relatively not totally simple, but relatively simpler.
This was ideally the initial fracture. What happened was more like an anterior column and posterior hemitransverse kind of a thing. The contained head.
That's the original, but he already had, one of that first picture after the index procedure. There's a fair amount of bone graft, and it looked as if the entire thing is the acetabulum side is all sort of forming a good amount of bone.
Yeah, sir. That it's almost the same, sir. It is almost completely formed, and this is
yeah.
The posterior wall, in these sections, posterior wall doesn't look too good. I mean, that's the only defect that I'm seeing.
But how far up or down is that section? I don't know.
Is all you will need for the acetabulum. For the femur, since it's an acquired deformity, acquired shortening in adulthood, not necessarily you will need an STSO. If we can do a 300-degree release, except the abductors, release everything else, including an adductor release, you might be able to get the hip down. But if that release doesn't help, then you can go for an subtrochanteric shortening. Yeah, it can come down even without an subtrochanteric shortening. We just need to do a lot of releases. And with this amount of ossification or myositis mass, that option is slightly more difficult. Getting to do so much release without.
Absolutely. Yeah, that's agreed.
But STSO won't get the GT fragment down, sir. It will just sciatic nerve lengthening. It can prevent like that only, no, sir.
Yeah, I mean the trochanter is already off, isn't it?
So yeah. It's more or less a supratrochanteric region only. There is shortening.
It's already functioning like an osteotomy. The trochanteric osteotomy. So, I mean, certainly a Wagner.
And even the traction, it's almost now 2.5 years post the injury, sir. The traction, skeletal traction, not even an inch movement of the trochanter coming down.
Yeah.
So a little bit high hip center like that, and then sinking the Wagner stem and then putting SS where we can manage, I think, getting the stem down like that.
No. I mean, the object of an STSO is to prevent sciatic nerve. That is what, that is the primary aim. The other aim is, if you're not able to get a good medial release, especially the adductors, the other thing that will help is, if adductors are contracted, then STSO will help you get the hip reduced. Abductors are not affected by STSO, but other tissues will be affected. Apart from abductors, everything else will.
They're all affected secondarily, in the sense genetically they're programmed to be longer. So if you release adequately, it will stretch. Unlike a dysplastic hip or something, or a hip which has been riding high genitally. Those tissues
but here there was one episode of infection, then myositis, mass, fracture, healing. It's a multiple process which was going on.
Yeah, that is if you want to look at the half empty cup. The good thing is that somebody put in a hip and all the tissues were out to length for for almost 3-4 months before it dislocated.
3
So
months. 3 months.
it had an infection and this myocyte is forming. So it will not be very easy to reduce this hip without an extensive release, which again is made complicated by the myositis. So I think I would go for shortening if I find it really difficult to release or bring the hip down. I'll be definitely prepared for doing an STSO here. And acetabulum might need, I think, a posterior graft where, yeah.
So should I go ahead? So
Yes, sir.
as expected, what were the things which I had in my mind is, of course, as Arun said, it's a myositis, completely with multiple infections and treatment and myositis fractures, multiple fractures. The exposure is going to be, it is going to be difficult, this is what I was expected. And of course, I was much worried about the coverage. So if at all posterior support is deficient from the CT scan, what I found is there was some amount of column and some amount of wall, so that a medialization might be beneficial so that I can come out with a normal cluster hole cup or something like that. Femur, as we heard, is completely up, touching your ASIs, with the possibility of whether coming down because the traction is not showing any positive signs that the trochanter is going to come. And of course, the proximal femur is completely mal-united, rotated, and anatomy is completely going to be a task. So these are things which I had, but this is what exactly happened is, so what I was expected happened, that exposure was completely fibrotic calcified. It was just stuck. There was no exposure. I was not able to go either anteriorly or either posteriorly. Any approach was not possible. So I have to be prepared for a lateral trochanteric, means I just have to knock down the trochanter at the level where I could expose the acetabulum. So that's how I did. It's like a whatever long trochanter which I had superiorly, I was able to, and it was merely not possible to mobilize the entire trochanter down. So if I would have attempted further, I would have ended up completely removing the abductors or making the trochanter naked. So I have to stop at that point, and then I thought I should go through a trochanteric through the trochanter, enter into the acetabulum. Of course, the trochanter was not able to come down, and luckily I was able to medialize my cup position. So I was able to come out with a normal 3-hole cluster hole uncemented cup. And coming to the femoral side, of course, I had an option of a grid blasted Echelon stem from Smith & Nephew. That's what I had, and because of the budget constraints and so on. So this was the immediate post-operative X-ray. Any comments or any take on this?
I have a doubt, sir. Why not dual mobility in this case, sir? Because there's some abductor deficiency we have used in the trochanteric approach.
Yeah, of course. That could have definitely a thought process. I agreed, and yeah, definitely this had some is an auto driver, had some budget constraint.
And then other thing in this case, impingement chances can be there lesser if you put DM cup.
Even now you have impingement chances. This trochanter is almost
increase the impingement chances also in this case.
Echelon stem can fracture also.
Kya, sir? What, sir?
Echelon stem cantilever mechanism, it can fracture and follow.
Yeah. This is cobalt chromium stem, sir. The chances are there. But still we use for low budget patients. Arun, any take on this?
I'm just trying to figure out. So you did an osteotomy distal to
I was not able to enter either anterior or posterior because of the myositis mass. Okay.
Okay.
So I have to go through the trochanter, whatever, at the level of the acetabulum. I just have to go through and through the cortex.
Okay.
Where we do it, when we do a total lip or a bipolar for a trochanteric fractures, we just split open superior and inferior and go inside.
Okay. And then what happened to the medial calcar, or is it, medial, what happened to the medial cortex?
Medial, there was nothing, no medial at all. Nothing was there. Okay. It was already gone before.
Okay.
That superior part is left uncovered. Below the calcar part of the stem, it is remained uncovered.
This is, I think we'll have to wait for it to see how it works in terms of getting a movement. And I think the trochanter will unite, how much he will be able to walk without lurch or something is a question. But I think it's a difficult case with so much of myositis forming on the thing. It is not easy to release and get this hip down without doing either I think an STSO or an osteotomy to get in. Yeah,
Sir,
maybe.
one doubt.
I think if vastus is still attached, then it will function like a digastric osteotomy. That is probably one advantage that you have here. I don't know if vastus was still there or
The
not.
point is, it was completely stuck. The tissues were completely stuck
Yeah.
from superior to down. So I was really not sure what I was going through at that particular, because everything is completely like a fibrotic tissues throughout the vastus lateralis, because multiple time operated
How much
infection.
shortening does he have at the end of it?
Now, you see?
Sir,
Yeah. At the end of this surgery, how much shortening is he having?
Yeah. Right now, it's almost 2 inches.
Yeah, so you left him shortened and I think given him a stable hip. Yeah.
Stable hip.
And when was this done, Bharat?
So 2 years before, sir. 2.5 years
Okay.
before.
So what was your immediate post-op protocol? Did you wait for him?
Yeah, sir. We went partial weight bearing, slow mobilization, partial weight bearing.
Okay. Because there's nothing on the medial side and lateral side
Nothing.
also hardly anything. So yeah,
I mean,
and lucky that he didn't dislocate because it's so close to the ischium. It can just sort of, So he didn't have any problems after that. He's walking with the 2-inch shortening.
Yeah, sir. So this is 3 months post revision. This is 2 years follow-up. The trochanter is still up. It's completely not in align with the femur.
He's got abduction.
yeah, looks good.
God is still there.
Yeah.
Luckily, there is no infection. It's a post-infective case. Good result, sir.
Oh my God, this is phenomenal. For
So
this
what
case,
is
first of all, to touch it, it's gutsy.
Yeah, clinically, he's
Arun,
looking better than
what I
even
have
radiologically.
learned is, what I have learned is, suppose if this trochanter or the piece would have united, the reason for his stable hip and such a mobile hip is because the trochanter has gone into non-union. Is that right? What?
It has gone into some kind of fibrous union. That's why
Fibrous union, yeah.
some
Fibrous
kind
union.
of fibrous union. That is why he is able to abduct like this. Without that, it will be fairly difficult for him to abduct like that. So some kind of fibrous union. It has gone anterior and above. So probably because it is so high, probably it is not coming into the. I don't know how it is not impinging. That is something that is still a mystery. Yeah, because I mean it has gone anteriorly and up, so that is where it is most likely to impinge. But yeah, good for him.
But he's now started his auto driving and he's happy now.
Yeah,
And
what
you put
This
in
was
a
6 months.
32 or a
to
36
avoid
head?
dislocation in the post-op?
That I think, sir, if I'm not wrong, the 2 years, it's 36 only, sir. If I'm not wrong, sir. 52
Yeah, looks big,
couple.
36. Yeah.
Yeah, looks 36. Yeah.
Yeah, looks 36.
36 only, sir. 52 couple, if I'm not wrong.
So
this was
what
two.
did you
This
post-op to avoid any dislocation, Bharat? I mean, anything specific you did or just
nothing. So what happened is what I felt is coming out of it was like a nightmare. Coming out, reducing and reducing the hip exposure. Maybe sometimes we might withhold. Okay, just we'll go out. We'll close the surgery. But somehow, step by step, we was able to proceed further. So it's like a on-table process of planning what to do next. Though we had plans A, B, C, but nothing worked because no exposure either from anterior approach or posterior approach. So everything evolved on table, and to a point, we were able to execute the procedures.
So you mean if somebody like this comes to see you again, you'll offer them arthrodesis?
No, definitely, arthrodesis is not an option, sir, at this era. Maybe this has given me the confidence that I'll go again for these kind of patients again.
Yeah.
Yeah, nice one.
Shall I add few points?
Sure, sir.
Yes, sir.
If the patient is a auto driver, you could have opted for a pelvic support osteotomy. That's what I think it is doing with the total hip. You don't have the trochanter, which will actively work as an abductor. That muscle is quite away from the shaft of the femur. And what exactly the hip is doing is it has got movement, and it doesn't give you a good normal gait, but it has given mobility. And with the help with the infection in this particular case, one has to be very, very worried to do such a heroic surgery. A simple option would have been a pelvic support osteotomy with the lengthening of the femur. He would have done well, because anyhow, this is an excision hip. So there the chances of getting problems are less, and everything is done with an external fixator. So probably that will be the option which you can give. What is the age of this patient? Because I have joined very late.
52, sir. 52.
52. Okay. You are not able to take the greater trochanter. Once you have done the transtrochanteric osteotomy, whether you were able to approach between the ileum and the trochanter, cutting off all the fibrous tissues, was it possible or not possible?
So it was completely not possible. The trochanter was not able to, we are not able to mobilize the trochanter, or not even able to, even a single 1 centimeter, we are not able to pull it down, sir.
But postoperatively, we are able to see certain amount of gap between the ileum and the trochanter, which was not there in the pre-op, immediate post-op. There is some amount of gap now we can see,
This is immediate post-op, sir.
Okay. Yes. Good.
What's the difference? What's it called? Defunctioning osteotomy compared to a pelvic support.
Well, you do a pelvic support, you get a elevation of the abductor latch, and since it is the distal fragment is abducted, you do a varization of the distal femur and lengthen at that level.
Comes under the ischium.
The pelvic support osteotomy is done at the level of the ischium.
Yeah.
And the distal fragment is abducted so that you get an armchair effect.
Yeah.
Now, since the distal fragment is too much abducted, you do a varization in the distal femur. By doing an oblique osteotomy, you can get the varization of the distal fragment and then do a lengthening.
Yeah.
If you are interested, next time I will show you that. I have done quite a bit of them. Probably 30 of them are there in my series, which helps in very young people whom we cannot